Welcome, ladies and gentlemen, to the Children's Mental Health Learning Series. This learning series provides free, helpful information and strategies for youth and their families, caregivers, and professionals who support youth with mental health issues. Increasing information for families and caregivers of youth about a wide range of mental health topics builds our capacity to support young people in Alberta. Today, as a part of the Children's Mental Health Learning Series, we are learning about suicide with a focus on youth suicide. Serious suicide attempts are uncommon from a larger population perspective. They are, however, an issue of constant concern for addictions and mental health practitioners. Today, we will look at the basic of suicide statistics. We will also learn about universal suicide prevention, suicide intervention strategies, and dealing with the aftermath of death by suicide or post-intervention. Leading us through this important and complex topic today is Dr. Michael True, Chief Addictions and Mental Health Officer with Alberta Health. Dr. True was appointed the Chief Addictions and Mental Health Officer for Alberta Health in June 2013. Like the Chief Medical Officer of Health, Dr. True is a member of the Alberta Health Executive and reports directly to the Minister, advising on issues, addiction, and mental health in the population. In his past role as Medical Director for Addictions and Mental Health with Primary and Community Care and the Seniors Medical Director of Addictions and Mental Health Strategic Clinical Network for Alberta Health Services, Dr. True helped with the development of the Creating Connections, Alberta Addiction and Mental Health Strategy, the Suicide Risk Policy Suite for inpatient mental health units, and the implementation of recommendations from the Provincial Elopement Quality Assurance Review. Dr. True blogs about mental health on behalf of Alberta, a link to which will be mailed to all of you, and also maintains clinical practice 1 day per week from his home city of Calgary. Please join me in welcoming Dr. True to the Children's Mental Health Learning Series. Thank you.
Good morning. I'm very pleased to be here to talk about a very serious topic, but I'm pleased to have a chance to go through some of the basics around suicide and suicide prevention, with a particular emphasis at times on youth, but much of what we know is actually appropriate and for any age group. So we're going to go through a little bit about some of the basic facts and epidemiology, then we'll talk a little bit about assessment, and then move on to talking a bit about prevention, and finally postvention, and then there'll be room for questions at the end. I would invite people to kind of make a note of questions as we go along, and again we'll have an opportunity to talk at the end. So we have a tendency now to begin with any talk with declarations of conflict of interest. I'm disappointed to say that I don't have any conflicts of interest. That would mean that somebody actually paid me for something that might be a conflict, so I'm a bit disappointed about that. I do need to say thanks to a couple of people with regards to this particular presentation, one being Catherine Davis from Alberta Health Services, who has helped me with some work on this with regards to suicide in the past. And secondly, Michael Sanderson from Alberta Health, who works on statistics in a number of ways, and we'll see a couple of his graphs as we go along. So let's start out with a question: are you a suicide survivor? And you don't need to stick up your hands, but I would ask you to stick up your hand inside. I never thought that I was a suicide survivor. I thought, you know, I'm a professional. I work with people who may be suicidal. I've had some patients who died by suicide. I didn't think of myself as a suicide survivor until I was at a Canadian Association for Suicide Prevention meeting a number of years ago, And they started talking about how people are touched by suicide and who becomes a survivor. And we generally think about family and friends, and of course those are the people who are most affected. But then I started thinking in my own life how many times suicide had touched me. And I think back to when I was about 10 and there was a family member, a family friend, not one that I knew very well. And then when I was going through university, and not one but two professors died by suicide. And then one of my colleagues that I went to medical school with, and he dropped out and then died in a single vehicle accident, which might well have been suicide. And then I went into psychiatry, and I thought, maybe I am a suicide survivor. And I think it is interesting that suicide is one of those topics that is much more common than we think. It touches many more people than we think. There's probably almost no one that reaches sort of middle age who does not know somebody who died by suicide, or certainly knows somebody who knew somebody who died by suicide and is aware of that, and yet we don't talk about it. One other thing before I leave this and this particular thing, and that's a comment about language. You'll notice that I use the term died by suicide. And I would invite you to consider that language. It's a language that I learned from some family members of people who've died by suicide. The term commit suicide, it sounds like it's a legal term. We commit acts of unlawful acts. And suicide has enough difficulties in its conversations without adding extra stigma to it. So I would invite you to consider the language of died by suicide as being the least problematic. Let's move on. Some quick facts about suicide in Alberta. We now have more than 500 people who die by suicide every year. Somewhat sobering. It's been one of the highest rates in Canada at approximately between 13 and 14 deaths per 100,000 people per year. And we generally run in the top 3 or 4 provinces in Canada for rates. Almost 75% of suicides are male, whereas females attempt suicide much more than men. The death rates, and we'll see some graphs about this, for suicide really account, males between 25 and 55 account for more than half of the deaths. And we know that Aboriginal youth are up to 5 times more likely to die by suicide compared to the general population and their peers. There have been public health concerns about rates of suicide since the 1950s, and prior to the 50s, or in the early 50s, the rates were below 10 per 100,000, reminding you that we're now in the 13 to 14. There was much higher rates, getting close to 20 per 100,000 in the 1990s. There we are. And one of the things that strikes me as I've looked at various suicide rates is in some areas in southern Ontario, the rates are in the order of 7 per 100,000. Why is that? Why is Alberta twice what some areas in southern Ontario would be? I don't have an answer for that, but it's one of those questions that I think challenges all of us to do some thinking about what we do and how we do it. This is a graph, and I apologize, the numbers on the side are rather small and hard to read. This is Alberta suicide rates between 1982 and 2012. And it starts, the highest rates run up to about 18, and the lowest rates are in the order of 13. And you'll see that there's some ups and downs, but basically it went from about something in the order of 17 per 100,000 in the 80s to somewhere 13 and a half about in the last few years. We don't have a very good explanation of why there's been these changes, but that's what we observe. Some people, especially around Christmas time, there'll be discussions about rates of suicide and when there's times when there's more suicides. And I would invite you to look at this graph. This is a cumulative 5 years of deaths by suicide in Alberta, and try and figure out a pattern. If anybody can figure out a pattern, please let me know what it is. There is some variability around an average. These are just total numbers that were simply added up month by month over 5 years. And there's some minor variability, but it is truly not very much. So if we're talking about calendar years and times of risk, it's very small. The changes are relatively small in terms of the total numbers of deaths. This is a bit busy and a bit busy graph about deaths, and this is by zone, as long as we have zones in Alberta. I'm not sure how long that'll last now, but anyways, it starts in 2000 and it goes to 2012. And you can see just that in general, Calgary is running along the lower end of that. Edmonton's a little bit higher. The north zone seems to be, on average, the highest, and there's more variability in central and south zones, and they've bounced around a little bit. So that's just, again, just so you have some sense of that. But what it does tell us is something that we've known for some time, is that in general, the risk is actually higher in rural areas than it is in urban areas. This slide got a little bit distorted when we tried to copy it, and so I apologize. The gestalt here is these are different rates in different areas within Alberta, and just to say that we can talk about different rates, but there is variability from place to place, and it's variability from year to year as well. Having said that, Michael Sanderson has found a couple, 3 or 4 places that do seem to be truly higher on average, higher risk areas. So we have some questions. Why do some geographies have high suicide rates? We know that there's some things for a long time. We've known that age and gender and mental illness and alcohol abuse, substance abuse in general, lower socioeconomic status, and simply being alive are risk factors for death by suicide. And the ones, they tend to go in clusters, so they are together. Again, Mr. Sanderson has done some statistics on this. I won't go through the details. I'll leave it to him to explain those details. But he developed an adversity metric, which was a combination of alcohol, substance abuse, and some socioeconomic measures for each geography, and really identified that the geographies with high suicide risks tend to have high levels of that adversity measure. So substance abuse, including alcohol, and socioeconomic problems. That makes sense to most of us. This is a graph of deaths by suicide. Again, this is just raw count data from going over 20 years. And you'll notice again that there's 2 columns here. The high columns are males and the low columns are females. And obviously there's about 3 times as many men as women who are dying by suicide. we also note that there's this peak between 20 and 24. And it's not a big peak, but it does seem to stick up a bit higher. And really, so at the age of the 15 to 19 group, you see a large jump from almost none in the 10 to 14, thank goodness. And then this single peak at 20 to 24, and then this broad rise between the mid-20s and mid-50s. So that's the raw data. If we then go to rates, correct this for population, it looks a little different. Some of the left-hand side of the curve looks more or less the same, but all of a sudden we have on the right-hand side in the elderly this rise in male deaths by suicide. And so just going back to remind you that the numbers in those, when you get to from 70 and older, the absolute numbers are actually not that high. But when you compare that to the rates per of living individuals, the rates actually go substantially up as you get up above about 75 or 80. You'll also notice that that is only apparent in males. So there's some end-of-life things here that are going on which is not particularly the central topic of today's discussion, but is something to be aware of nonetheless. So we've got, but again on this rates, we again see this bump in that 20 to 24-year-old age group. So what does that represent? And I think there's a number of things that it represents. It represents that time between high school and the rest of your life. I don't think we're particularly good at connecting with people, especially young men in that age group. I think many of them sort of feel somewhat lost. And there's this other thing that, thanks to Patrick McGorry from Australia has pointed out, that this is a graph of the incidence of disease across the lifespan. And this big, is that orange? I'm really bad with color. Blip there in the middle that peaks at 20, that in fact is the incidence of mental disorders, which includes substance abuse. And you'll see that really between 10 and 30, there's this huge onset of illness. And that, I think, is also one of the factors of why that 20 to 24-year-old males are also at risk in a substantial way. You may have other thoughts to add to those as well. How do people die? Well, this is very Canadian data. This is Alberta data, and is not the same as what you see if you go south of the border. But you'll say, in spite of, so the largest group here in both men and women in Alberta is death by hanging. Something less than 20% of males will die by firearms. If this was U.S. data, half of the suicides are gunshots, wounds. So if there's ever an argument about gun control, that is it. And then it goes on to other things, carbon monoxide. Overdose, especially in women, is right up there with hanging. So let's, if we're thinking about the picture of death by suicide, we might think, okay, for every death by suicide, there's about a little over 5 people who are hospitalized for concerns about suicide. There's something in the order of 17 ER visits for suicidal concerns. There's something just south of 200 people of thinking about suicide that year, and lifetime it's more, it's between 800 and 900 people who will consider suicide at some time in their life. So if we put that into a picture, it kind of looks a little bit like this, which tells us that truly death by suicide is this little peak of the iceberg that sticks up and represents so many more. And those are people who consider, we're not talking about the people who are close to them, who may be affected by all of this as well. So we know that one of the risk factors is mental disorders. So when if we think about mental disorders in people who die by suicide, they suggest that probably 95% of people who die by suicide have either a mental disorder or a substance abuse disorder. Always a little curious about the other 5%, but we'll not dwell on that for the moment. Probably half of them are depressed, have significant depressive symptoms. This is from retrospective data. It's always a little bit tricky to make diagnoses on a retrospect, but this was actually out of New Brunswick and was done with psychological autopsy data. Almost 2/3 had substance abuse. But when we were looking at who's connected with the mental health system about a decade ago, of the people who died by suicide, probably only 15 to 20% were actually connected with our addiction mental health system, which, let's turn that over. That means that 80% of people are not really connected with our systems that are designed to help people who are affected, you know, the 95% who have some sort of disorder. Let's, if you ask the question, what kind of diagnoses, mental health diagnoses, are associated with suicide and the relative risk, you'll see down at the bottom there, it's got the general population, and you can pick your particular favorite disorder to attach a relative risk of suicide. And again, these are deaths by suicide as opposed to attempts. You'll see at the top there is prior attempts. The biggest indicator of future risk is your past behavior in terms of attempting to end your life. And then it goes from a group including eating disorders, major depression, bipolar, and mixed substance abuse, and goes on down from there. Having alcohol abuse, you'll only have a six-fold increased risk. So let's shift, if you're not sufficiently depressed yet. Let's move on to talk about assessment for a little bit. And you know, I think about assessment, and I was thinking a little bit about this, and I realized yesterday was my clinic day, and I don't have a big volume practice anymore. I actually have this small practice. There was 3 people yesterday that we had serious conversations about whether or not life was worth carrying on. And we can talk about those. One of those actually was the right to die. And that's, I don't see that as suicide. That's a little sidebar. If you want to ask questions, we can go to there. And this is a woman with a very serious progressive neurological disorder. But the other 2 were people with long-term mental health problems who are struggling right at the moment. So when we talk about risk factors, we sometimes split them into static or active or modifiable. Static being the things that you can't modify, and we know there's some pretty basic things. We know that, as we've talked about, there's in terms of age, there's peaks. There's that peak in early youth or in those early 20s, and then basically 30 to 55 is especially with men, but it's the same shape curve in women. That's where the bulk of the deaths by suicide lie. Again, being male is a risk. 3 to 1. But when you talk about attempts, it's much more common for women. And that's partly because of the use of pills. So they're much more likely to overdose, and consequently much more likely to be the possibility of being saved from an overdose. One of the things that modern pharmacology has done is it's given us a much better group of medications that it makes it much harder to kill yourself, with some exceptions, but the antidepressants that we have available to us now are actually not easy to end your life with, which is very different than when we had the tricyclics. The sleeping pills that we use now, benzodiazepines, are on their own very difficult to kill yourself with. And before the years of, before Valium became popular in the 60s, they used barbiturates, which are actually very easy to kill yourself with, relatively speaking. We know that previous history of suicidal act is a high risk factor, as we've seen already, and that once you've done that, it becomes a static factor. And of course, we know that family history of suicide or suicide attempts also seems to be a factor, and is probably from multiple levels. One of which may have something to do with breaking the taboo of suicide within a particular family. There's thankfully we've got a few more things that are modifiable. There's the word modifiable gets a little abused on this slide, and I apologize for that. Certainly, we know that current psychiatric illness is modifiable. We can treat people with depression. We can treat people with psychosis. We can help people with substance abuse. Those are modifiable. Recent or stressful life events or losses, that's not really modifiable, but time is a factor that helps most people with that. So if you can help them hang on through a crisis, that does modify in itself. So we've got recent change in treatment, and you'll see I've identified discharge. One of the highest risk times for death by suicide is in the days to weeks after discharge from hospital. And I think that that's something that we've been trying to do some work on. I think there's more work to be done, but that truly is one of the high-risk times. Ineffective coping, we can sometimes help people with that. Lack of social support, access to lethal means, and especially guns and pills. And I think that we need to remind ourselves to ask about access, especially to guns. Guns are the sort of thing that there's no coming back from. There isn't a second chance. Lack of hope. Hope it turns out to come up in literature over and over again about a key element. And if there's one thing we want to focus on, it's hope. And when people view the only solution to their dilemmas in their life as ending their life, that is risky. Let me talk a little bit about 2 or 3 scales for a moment, and these may be helpful to you. The Columbia Suicide Severity Rating Scale is, and it has come out in the last few years. It breaks things down into basically 4 different realms. Severity of thoughts, and whether they're active or passive, the intensity of the ideation, how frequent, how long it lasts, how much they have a sense of control, are there deterrents, and what the reasons that go along with the ideation, suicidal behaviors, and especially how directed the actions are, and the lethality and of the potential action. You can find it on this particular website from Columbia University. it has some encouraging. I need to tell you, in the past, there's been lots of scales about suicide, about assessment. Almost none of them had any data to go with them. And the Columbia Rating Scale is probably the first to have any supportive data that actually links the results of the scale with outcomes. So that's encouraging, because one of the difficulties in dealing with this area, of course, is that when you're talking about frequency of behaviors that are measured in per 100,000, you have to do an awful lot of work to see any change. And so we often in research will see people using suicide attempts, which are at least a factor of 10, as an alternative thing to look at. But that's it's not the easiest place in the world to do research to actually show some differences. Having said that, the Columbia Rating Scale has been encouraging in terms of consistency, sensitivity, and some degree on predictive value for especially a suicide attempt. And there's been some anecdotal positive results with regards to using this systematically and finding that that when it was used systematically, it actually helped pick up a number of people who were not previously identified and then be able to actually do something with them. So that's I think very encouraging. I know that some folks in the South Zone have been certainly doing some preliminary work in terms of considering using the Columbia scale. Another one, and this one is called a SAFE-T. This is another one out of the United States. And they basically had a 5-step approach to evaluation and triage, identifying the risk factors, identifying protective factors, doing a specific suicide inquiry, determining the risk and intervention, and then our favorite thing is documentation. That's probably another discussion about documentation and medical legal aspects. We'll probably leave that. There is a website that details this in more, goes through it in more detail, and I recently sat through a webinar in service that's online, and that if you're interested, you can probably pull that one up yourselves. One that I've seen a number of ER docs use is this Is Path Warm? Again, this is one of a number of these kinds of screening tests that seem appropriate, but there's really no confirmatory data to go with it. Again, the trouble with working in this area about the numbers needed to really show that it has something. But I don't know your experience, my experience with people who work in emergency is they love these kind of lettered lists, and so I've seen it a number of times used by folks in ER, and I'd rather they use something than nothing. Let's go there. And it certainly connects with a number of things that we know that are risks. The other side that we sometimes, especially I have to confess, in medicine, we have a tendency to be very pathology oriented. We have a tendency to want to define what the illness is, what the problem is, and sometimes forget about the other side, and that's the protective factors. What are the strengths and strength-based things? And clearly, when we're dealing with suicide, focusing on strengths is incredibly important. And I would say in dealing with adolescents, that's doubly important. So we can talk about protective factors in terms of internal and external. Internally, there's your ability to cope, your ability to tolerate frustration, and possibly your religious beliefs. We know that for many people, they have suicidal ideas but would not contemplate action because of strongly held religious beliefs. I'm always thankful when I run into that. Externally, around the person, there are other things. Responsibility for others, for your children, for your pets, for whatever, is often something that people hang on to. And so I can tell you that with one of my people yesterday, we reviewed his connections with his 3 adult children rather carefully. At least I thought we did. I'm not whether he thought we did is perhaps he needs to comment on. But that I think that is one of those threads, those strings that we pull on, and I do that shamelessly. Positive therapeutic relationships are known to be helpful. And so people who have longer term, or as in more than 1 or 2 interactions with somebody, we can then start building those positive therapeutic relationships that really do help people get through difficult times in their lives. And then there's the much larger area of social supports, which are, again, we know are protective factors in many situations, suicide just being one of those. So what are our goals of intervention? I think we need to infect people with hope. We need to think of ourselves as kind of an infectious vector, infectious disease almost, that we're trying to expose them to, let it rub off. I know that for some of my patients, I have been the carrier of hope when they didn't seem to be able to carry it themselves. And I think that is a legitimate thing that therapists do over time, and we should understand that that's one of our roles and not be afraid of doing that and identifying it as such. We want to build on strengths. We want to help remind people to connect with the supportive people around them, both personally and professionally. And obviously in different settings that will look differently, whether that is meeting them in a clinic, meeting them in emergency, meeting them wherever. There's this reference to a safety plan. I'm going to come back to that in a minute. But a safety plan is really about, okay, what do you do when? And I'll talk a bit about more of that in a minute. And of course, one of our jobs is to treat underlying conditions. So if they're depressed, we want to treat their depression. If they're abusing substances, we want to try and help them with that. Let's go back to the safety plan. There have historically been discussions about things such as a non-suicide contract. It was an interesting idea that took a left turn in a very unhelpful way. Some people who, I think the idea of a suicide contract, when it is with somebody that is well known to the patient. So if it's one of my patients and I have some sort of an agreement that you're not going to attempt suicide, well, I have a connection with my people that I've seen a number of times. There's some emotional leverage that might go with that. It got, thank you, the United States, it got to this sort of seeing somebody in emergency and signing some form for somebody you have no emotional connection with to say, I'm not going to attempt suicide. Well, it's not worth the paper it's written on. There was never any data to support it. It was badly abused. So I know that in Alberta Health Services we stopped supporting that and actually advised against the use of the suicide contract. What we asked people to do was to focus on this idea of a safety plan. Safety plan is this kind of list of things that you do or that they can do for themselves when the suicide thoughts go up. So it's it's a list of what they can do. It's in their words. It's done with the patient. It's something they can take away with them, because you probably are aware that when you're under high degrees of stress and arousal, your ability to call up information about what you've known before is actually crummy. So this morning, I get this phone call that says, Dr. True, you're supposed to be calling in to an audio conference line. In fact, you're the one with the code. Not, oh yes, oops. So I might feel a little stressed or a little preoccupied about doing this talk. I couldn't remember where I put the code. It only took me 5 minutes. I found it in the end. But it's, that's me. My biggest problem is talking to you folks for an hour, which I'm quite okay about. And I have that much trouble processing what I know. If my patient is seriously thinking that life isn't worth living, it's really hard to remember what we talked about 2 weeks ago or 2 months ago to do when they're feeling in crisis. So it's really important for that to be written down. And really it's about a commitment to the process of treatment and staying alive, but it's their commitment, their words, and really trying to come up with the best plan. And it includes things like, what can I do? What sort of diversions help? Do I like listening to the music? Do I like going for a run? Is there somebody I can talk to? And ultimately, after about 3 or 4 or 5 or 6, there's the Denny's option. Emergency is always open. So that's what a safety plan is about. Oh, there it is. Warning signs, internal strategies, distractions, your own network, professional network, and environmental safety. Sometimes we forget about, the safety of the environment. Gun availability is one of those safety things. Maybe pills. How many pills do you have around? Those sorts of things. Environmental safety is actually a fairly significant issue on inpatients, and we can make our inpatient units, and there's been work to do that, to make them safer. Let's talk about going upstream, something about prevention. Now, I know that as a physician, as a clinician, I tend to be pretty focused most of the time when I've got it on who's sitting in front of me and what are we doing. When I step back and I do a fair bit of administration work now, I need to take a different view of things, and I need to think about, this not just in terms of this particular individual, but about suicide prevention, intervention. That's the clinical bit, and postvention. What happens when the worst happens? After the worst happens, and then we can act. We can focus on different levels of action. Universal, that's where we do things with everybody. That's education programs or that sort of thing. Selective, where we're taking higher risks. So we're looking at, talking about males in the 20 to 24. That would be a selective risk or level of action, or an indicated level of action. That's the sort of thing where you're dealing with people who are depressed. We know that depression is associated with suicide, and so that would be an indicated level. This is a graph and that some of you may have seen, and it's to remind people about the different kinds of or levels of care and for intervention. So that big green space is all of us. That's everything. We call it Tier 1. That's the public health of the public. So we might have education programs, we might do some public service announcements, we might do some things about mental health literacy. Tier 2 is essentially primary care and sort of general public health clinics. And so we might do some things there. Again, and that might have to, some of that might be screening. Have to do with using screening tools. and interventions at that point. Tier 3, 4, and 5 are really the mental health addiction system. Most of us, certainly that's where I've lived most of my life, and that's what I usually think about. But it's useful to really to remind ourselves that there's this, when we start talking about prevention, we need to be talking about the whole enchilada, or the egg, if you wish. So, some challenges. As I mentioned before, 80% of those who are at risk or who end up dying are really not connected to the addiction mental health system. We got high numbers of people who are, some studies have shown that if you look in the months prior to death by suicide, 2/3 or more of people have been in touch with the primary care system. But they're not, they're often not, they weren't recognized, weren't necessarily screened for suicide and suicidal ideas. There's all these help-seeking barriers, and really that comes down, number one, to stigma. People saying, I'm not going to reach out because. And we're in Alberta, so we've talked a fair bit about adverse childhood events, and so we know that high adverse child event scale scores are also associated with suicidal attempts and deaths by suicide. And we must remember the social determinants of health. So if you, that's one of those words that tends to float out there, but includes things like income and social status, it includes education, it includes social environment and personal health, behaviors, gender, culture, a number of things like that. And we know that those are associated. So levels of action. I mentioned before, universal actions that are really target at the whole population. There's selective, that means groups that are particularly at risk, so Aboriginal youth might be a particular selective strategy or program, and we've done that. We've got indicated programs. Those are the individuals who are at high risk. So those are the people, for instance, who have mood disorder, those people who are multiple substance users, or worse still, the combination of a mood disorder and substance abuse. So we need to focus on some areas of action, areas where evidence suggests that we can really make a difference. And what areas are those? Those are things like communication and coordination, things like building capacity, and encouraging and facilitating help seeking, and recognizing these are areas that are not separate and distinct, but really kind of they interact with each other. So let's talk about some of those. So there's things like school-based programs and suicide prevention programs. Some of those are suicide-specific. Some of those are more resilience-oriented. That would be that. And again, some more public education campaigns. So, for instance, we have Mental Health Week, a public that's going on right now. That would be one of our public education campaigns. The whole business of health literacy, or in this case, mental health literacy, and media guidelines. We know that media, excuse me, that the reporting about suicide in media is not a simple matter, that it can have some real impact on the people who hear, read, see stories about suicide. We'll come back and talk about that in just a minute. And recognizing that increased interconnectivity and trying to break down some of the silos of various stakeholders, including different departments in government and levels of government, whether that's provincial, whether that's local government. Know that research and evaluation is part of this. increased access to information, knowledge translation, which is really putting what we know into practice. We know that we're not really good at putting into practice what we know. That some people have suggested it's 15, 17 years between new evidence is discovered and it actually is in regular practice. Or maybe that's just doctors, I don't know. Anyway. Building capacity is things like enhancing coping skills, improving the screening, detection, and treatment of depression, education and training of professionals, and general awareness and knowledge within the population themselves. We know that part of it, of building capacity is really trying to use the natural community connection points. And we've got a few of those, schools, clinics, workplace, liquor establishments. Can you imagine using the liquor establishments as a way to transmit some of this information? Sports, agencies, faith-based organizations. We have lots of possibilities, and I think often we don't use them well enough. Let's talk about adolescence for just a moment. We know that that in terms of these are protective factors in moderate depression and stress. This is actually risk factors. For girls, it's about hopelessness. And for males, it's keeping to themselves. So it's a higher, those boys who go and hole up on their own and just quiet. That's a risky group in adolescence. Having had at least one of those in my household, he wasn't depressed, but he would tend to kind of hole up. It's risky. Some non-productive coping that increases problems with depression in adolescence is worry, using too much wishful thinking, just ignoring the problem. Has denial ever been a problem in adolescence? And blame making. It's somebody else's problem, somebody else's fault that I can't control. Protective factors are in women and girls have to do with focusing on the positive. And one of the things that was determined, it's a bit different for boys, was more around sort of a spiritual self-discovery. And this is where we start to trip over some of these differences between males, females, boys, and girls. There's some of those that are interesting, and I think interesting areas to grow and understand more. So when we want to facilitate help seeking, there's things like peer support and enhancing social networks, increasing access to resources and treatment, improved health literacy, stigma reduction. Those are goals that we're all looking for. Just a quick spin through a couple of, to let you know that there are other places that have struggled with this. So Australia, Scotland, New Zealand, England. Those are some of the places. I'm going to skip through this fairly quickly because I see my time is getting short. So each of these places has had different strategies, and you can see some of them more general, but some of them quite specific. So the Scottish Choose Life, whereas something like breathing space is not quite so specifically directed towards suicide, but certainly around depression. Australia, their Headspace program is received quite a bit of attention locally. And again, both in Australia and New Zealand have some similarities to Canada in their need and their struggles with Aboriginal youth. Scotland's done a fair bit of work on training in suicide prevention. These are all in your notes. And the MATES program, MATES in construction in Australia, you can guess what the target for that was. places doing gatekeeper training, you know, who to try and kind of help people recognize when somebody's not doing so well. In Alberta, we've done a few things. We've done things like the Community Helpers Program, which has a number of sites in the province. It's really targeting, trying to find people who youth would connect with normally, and teaching those connection points, something about how to recognize when people are struggling, and do they need something more? Do they need to be connected to professional resources? There's Men's Shed in Australia, which, and the mental health capacity building projects in Alberta. There's a resiliency program here in Red Deer, based out of the schools. Those are some of the things that we probably need to do more of. So, the worst happens and someone dies by suicide. And then we have this process that we talk a little bit, we sometimes use the term postvention. And we need to support the families, because for one thing, the family now have joined a group of higher risk people. So postvention really is prevention. They often struggle with complex feelings, mixtures of anger and guilt, occasionally relief. So often the sense of shame and isolation, difficulty talking about this because of this difficult set of mixtures. It's interesting talking to people who've lost someone by suicide. There's this mixture of the grief of losing someone very close to you and the anger at someone who killed someone you love. And how do you hold those two things together at the same time? A complex mix. So, and all of the physical, social, spiritual impacts of grief, sometimes complicated grief. There's situations where there needs to be support to other patients, especially if death by suicide has happened within a hospital or a closed setting or a day program. There needs to be this, again, sometimes difficult combination of emotions for this other patient who had some connections, and that can be mixed up with their own problems, why they were there in the first place. May require on inpatient units an increase in general safety measures, canceling of passes, reviewing the environment of safety. Actually, sometimes having a community meeting to provide the information, and then following that up with more individualized support. Because some people will not be terribly affected, others will be very affected, and sometimes it is difficult to predict who is going to be in which of those categories. Sometimes we forget about staff. Staff are very much affected by deaths by suicide. And I need to mention that includes the medical staff, who are usually they're noticeable by saying, initially at least, I'm okay, my job is to help everybody else. There needs to be some sort of venue or for review of the case that is safe. And there's need to recognize that there is a process to be worked through. That may be helpful to have someone from outside the unit to facilitate. And one thing that I don't think we have often done very well is meeting with the family. And we need to, I think, consider how we do that. I think it is, when it happens, it's usually very helpful. Although it can be very difficult, it's ultimately helpful to both the family and the staff involved. A couple words about suicide contagion. We see clusters of suicide at times within certain communities. The most common are within school settings. And there's this interplay of pre-existing risks and the social context, and the trigger. There's not been a lot of work on this in terms of, but there has been some. And we do see that there is this risk of people who have had suicide, or attempted suicide, for people who have been schoolmates of somebody who's died by suicide. Interestingly enough, it's not necessarily somebody who's really close. And I think that that's almost counterintuitive, and it's confusing to us. Probably talks about the mixture of pre-existing risk with what's going on at the moment. We know that it seems to be the younger kids, so these are the kids in their very early teens that are a higher risk than older teens. And that risk can last for 2 years or more. So it's not necessarily a short-term risk. And that people who are working with this, we often I think well, we'll get through the next month or two and then it'll be okay. And that's not actually what the data says. It's longer than that, which tells us that we probably need some sort of universal intervention at that point, at least for that community. Right. So there's things about those that we know are already at high risk. We're going to monitor closely, of course. Some of them may require admission. But as I said, there needs to be a general response for that because there's a general elevation in the risk. We need to be careful about memorials. And I don't think this is one of those times where you can't say never, but you need to say it needs to be carefully thought of. There is this risk of idealizing both the individual who's died and unwittingly the way that they died. And so it needs to be carefully worked through with the family. And actually engaging with the media may be helpful because the media, especially if there is a sense that there's a cluster, their automatic response is to make that very well known, and that is that there's a real risk to that. There was in a related, not quite a cluster, but there is this Me Too response that we see occasionally. In the 80s, there was a series of deaths by suicide in Toronto subways that only stopped when they convinced the media to stop covering them. So the media does have some very real impact here. And I think that schools that have mental health programs, be they capacity building or resiliency programs, they just have more tools to work with when they're put into this kind of a situation. And just another thing, that interventions don't always have to look like their mental health. So things like social activities, sports activities, those sorts of things that actually collect kids doing positive things are also interventions that work. It doesn't have to be, we're going to sit down and we're going to talk about tough stuff. There may be times where that helps, but it doesn't have to be just that. Media, just a couple of things. We've been worried about this in the effect of media because of that Me Too sort of response. So I'll remind you of Kurt Cobain, who died in the 90s, and there was a little bit too much advertising about just what happened, and my recollection is there was a fair bit of copycat behavior from young, especially men. Ironic when you think that he was the lead singer for Nirvana. And then Robin Williams, very different set of media coverage in last summer. And I don't think I've heard of any. Now, if the media were doing a really good job, they wouldn't tell me. about the Me Too's, but we never heard about how he died. You had to infer that. And I think that that's part of what we see from media. Some of the recommendations are that they not focus on the method, not to romanticize the death, and that when there is reporting that it's linked with signs of risk and sources for help. There's a link to the Canadian Association for Suicide Prevention media guidelines. I think that I'm going to skip quickly through, but just to remind you, because I'm already 10 minutes over, the community development really is the key to suicide prevention. We're important bits. It's not just addiction mental health and mental health treatment. It's not that we're not important, but it's a much bigger picture. So it's the community as a whole. And we have this tendency when we get into this to automatically jump to treatment and forget that this prevention is this much bigger picture. Oh yes, First Nations, just a quick mention that there's some pretty good evidence that there are lower suicide rates in First Nations communities that actually manage their own self-government, have settled land claims, have better education, local policing, and their own some cultural activities, and higher suicide rates associated with poverty, low levels of education, high unemployment, and poor housing. And I'm not the one to talk to you about this, but it sounds to me like the imprint of our colonial activity to First Nations and intergenerational trauma. So as a professional, we need to assess well, treat well, connect with the person, build a safety plan, and recognize that we are one thread in the web of everybody's life, an important thread, but only one thread. As individuals and family members, we talk to people. We normalize that suicidal ideas are part of many people's life at some point. At least a third, probably closer to a half. We try and give non-judgmental support. We try and encourage positive and active coping, and we call for help when it's needed. And as community members, we talk about reducing, in order to reduce stigma. We talk with individuals, we talk with groups, we talk with governments. We respect other people, and we encourage the community networks of caring connections. And we become vectors of infectious hope. So, prevention is difficult to measure. It's complicated. Suicide is complicated. It's the gold standard would be a real reduction in suicide and suicidal behavior. And the areas to look at are communication coordination, building capacity, help seeking. They're interconnected, and we focus on these three areas to really build suicide prevention in Alberta. And the real challenge is that no one group, no single individual, no group owns this. So, really is everybody's business. Some websites, and those will be on your notes, and 10 minutes late, I'm ready for questions.
I'll get us started.
Oh, good.
Patty S. is wondering, do you have ideas for engaging and supporting primary care to screen and support patients at risk?
Engaging primary care. I think what primary care needs are ways to fairly quickly not only screen, but what do they do next? Their worry is, if I find somebody and they've seemed to be at higher risk for suicide now, is this going to take me another 45 minutes to sort out? So part of what we need to what primary care providers need is not just a quick screen. And of course, a quick screen starts with, how are you doing? And about the third or fourth question is, do you have any thoughts of hurting yourself? Is it that bad? What are the next steps? And so in primary care settings where they're working within a team, and they can there's the potential to hand that off fairly rapidly to another team member who might have some more time. That's going to be a lot easier for them to do. The other things, of course, are effective and efficient connections with mental health supports if they feel they need those.
Carolyn is wondering, what recommendations do you have for families as their depressed teens entered adulthood? The family has very little say and influence over non-compliance with treatment, etc.
Yeah, I think that dealing with young people is a challenge, because they're caught at that stage in life where they're trying to. The normal trajectory is for them to decrease dependence upon parents and family, to increase their independence, which usually means they talk less about many things, and often that is somehow that is interpreted as, I don't talk about the things that are really troubling me as much. So part of the trick, I think, is trying to have conversations with their younger member, their young adult, that says, basically, I have some ideas about what might be helpful to you, but my number one idea is that you should not be in this alone, and that I want to be helpful. Doesn't mean we always have to agree, but we want to be helpful, and we need to keep open that conversation. Good.
Before I go to the next question from the web, are there any questions in the room? All right. Oh.
I thought it succeeded in baffling everybody there.
Just following up with what you just said, our experience with youth here is that we take them to ER and they sit for 6 hours, 8 hours, and by the time they're seen, they say they're fine because they're just sick of sitting there. Yet, the suicidal ideation is still there. Any suggestions for that? Because that's our system.
Right. Well, I think actually the first thing is that most. I didn't get into this, but one of the issues around suicide is you can also split them out into sort of longer term concerns and impulsivity. And one of the problems and we know that many people will have self-harm ideas that don't act on them until they're most of the time. And the element of impulsivity is the risk that sort of background ideas get acted out on an impulsive event. Now, adolescents, of course, in and of themselves, are at risk for impulsive behavior. You add to that, and that's probably one of the big factors around substance abuse, because that also feeds the whole acting in an impulsive way. And so one of the things, so let me go back to your scenario of the 6-hour wait in emergency, and well, of course I don't feel like hurting myself anymore. Mostly I want to go home to bed. And you don't have to be 18 or 21 to come up with that solution to the particular immediate problem. And then I think the next thing is, okay, if you've had that once, there's good chances that you may have some of these thoughts again. What do we do about that? Which enters us into the conversation that looks like a suicide plan, or a safety plan, sorry. And that's not likely to be worked out in Emerge. It's more likely to be worked out with somebody that kid knows. whether that's a family member, whether it's a friend, whether it's a professional. And I think the idea of a safety plan makes sense. CAMH has a one kind of template for a suicide plan on its website. It looks pretty reasonable. I don't think you'd need 10 hours training to figure out how to fill in slots. And I think, so that's one way of approaching that. Do we need things to be a little different in the system? That's another conversation for another day, but I guess the short answer is, yeah, that we can all think of things that need to be improved.
Next question from the web is, what are your thoughts on the effectiveness of suicide intervention training for caregivers and staff working with children and youth in care?
Well, we know that children and youth in care are a high-risk group. And so it is important that that people who work with those kids recognize it when it's there, that they're able to have a conversation about it that that says to the youth or kids in care that this is a conversation that's possible. It's not going to be followed up with some kind of recrimination or punishment. It needs to, because we know that if whoever's asking the questions is comfortable, you're much more likely to get realistic responses, and you can then move to, is that something that can be managed with the resources that are immediately at hand, or do we need to go to another step? And again, let's remember, if we go back to that reference to ACEs, adverse childhood experiences, kids who are in care are stacked with those. So,
what are your recommendations for how a school should handle the death of a student by suicide? We understand it's a touchy subject and it requires careful thought, as you mentioned.
Yeah, I think there's, let's assume that this is a kid who is actively enrolled in the school, because there are deaths by suicide for kids who are kind of on the periphery, and that's harder to judge. But we'll assume that it's a kid who's actually actively been going to school. I think that the first thing is that denial of that is doesn't go down very well. So silence doesn't work. So if silence doesn't work, because the kids have their own networks and they are electronically enhanced these days, so they will probably know before the teachers do that A, somebody's died, B, that it was probably by suicide, and it goes from there. So so if we go from there and we say, okay, there needs to be an overt response, I think that will be managed within the school, but it probably includes something that says kids and communication to the family as well, direct, with send home paper or whatever, that says, we understand Johnny has died, that he did so, that was a death by suicide, he did that. We think that that's terribly sad. The worst thing that could happen is that that would happen to anybody else, and we're particularly sad that he was not able to find the help that he needed to get him through this time. And then to go from there, recognizing again that teachers always are aware, and the administration are aware of their high risk, at least some of their high risk kids. So you're going to want to reach out to those specifically, but then recognize that there's a number of kids that are not going to be on your radar that need to be. And the question is, when do they pop up? Is that going to be the next week, next month, next 3 months, and just recognize that that in fact is a something to be continued to watch for.
Are there any other questions from the room? Then I'm going to be asking you the last question from the web now. In your opinion, how in early childhood and adolescence should suicide awareness be presented?
I think that, again, in earlier childhood, I think about my own experience of becoming aware that one of my mother's friends' sons had killed himself. And as many things in childhood, that's the opportunity for a conversation. And the conversation goes about, this is very sad. And in fact, we understand death by suicide is something that we don't think should happen any more than a death by a car accident should happen. And that sometimes people have difficult times, but we need to find ways to help them. They need to have ways of talking about that. So I think as younger children, that's the way it needs to be presented. And analogous to that, I think it then, if there is a way of talking about mental health literacy within a school population, whether that's maybe junior high, that again becomes part of that larger conversation about mental health literacy and described as something that happens more than it needs to, that it is, and that we are all left sad. I think one of the things that, and I would say that one of the things I have seen in some people when they're really seriously thinking about suicide is they substantially underestimate the impact of their death on people around them. Okay. Sure.
So I just want to take a minute and thank Dr. Tu for your presentation. It was wonderful. And very, very informative. I have a shopping list of highlights of things that I learned or things that I took as important learnings. I only have a few minutes though, so I won't go through them all, but certainly the risk and protective factors, the demography of suicide in Alberta and in Canada, some of the goals of intervention and levels of action. Am I not loud enough? Okay. The prevention continuum, some of the international strategies that have worked around the world. But the two most important messages that I took out of your session is that we are, in some way, all of us are survivors of suicide. Whether it's in our family, our school, or our community, we've been impacted by suicide in some way, and that we all have a role to play. And the thing that I just love, my staff will know I love, is that we are all community resources, and we can infect people around us with hope. Quotes every day, things like that, and exposing them to optimism and fostering that caring connection with other human beings, whether it's someone you work with or someone you go to church with or things like that, and building on their strengths and their existing resources and helping them to get through a tough time. So that was very meaningful for me, and I thank you very much for that. Just a thank you to our in-person and web audience for taking the time to join us today. And reminder that our next session will take place in Edmonton on June 16th. We will have Sue Huff from the Eating Disorder Support Network of Alberta presenting on helping children and youth recover from eating disorders. So we ask you to be sure to check out the website to register. For those who registered for today's session, there will be a follow-up evaluation and a link to the recording sent to you by email later. Your certificate of attendance will be emailed to you once you've completed the evaluation, and this session will be available online in a couple weeks. If you want to watch it or any of the previous sessions, you go to the Human Services website, and it's supposed to be up on the screen under CMH. But It'll be on the webcast. Okay, so thanks very much for coming and hearing about our very important topic today.